Radical neck dissection overview. There is hope for every cancer patient. Examples of head and neck tumors. Example of a neck mass. Radical neck dissection, or RND, refers to the removal of all ipsilateral cervical lymph node groups extending from the inferior border of the mandible superiorly to the clavicle inferiorly, and from the lateral border of the sternohyoid muscle, hyoid bone, and contralateral to the anterior belly of the digastric muscle. This is the anatomy of the neck. Another slide showing the anatomy of the neck. There are three main types of neck dissection in surgery. Radical neck dissection: all the tissues on the side of the neck from the jawbone to the collarbone are removed. Modified radical neck dissection: this is the most common type of neck dissection. And number 3, selective neck dissection. Modifications to the radical neck dissection include the following. Type 1, the spinal accessory nerve is preserved. Type 2, the spinal accessory nerve and the internal jugular vein are preserved. Type 3, the spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid are preserved. So this is a slide showing the anatomy of the spinal accessory nerve, the sternocleidomastoid, trapezius, cranial part of cranial nerve 11, and the vagus nerve. Which structure is not removed in radical neck dissection? Important extranodal structures such as the spinal accessory nerve, internal jugular vein, and sternocleidomastoid are sacrificed. Post-auricular, periparotid, suboccipital, perifacial, buccinator, retropharyngeal, and paratracheal nodes are not removed in this nodal dissection. This is the slide showing the anatomy of the facial nerve in relation to the other nerves of the neck. What are the levels of the neck? Level 1A, Level 1B, Level 2. So the Level 1A is the submental triangle, the Level 1B, submandibular triangle, and the Level 2 or the upper jugular nodes. Level 3, middle jugular nodes. Level 4, lower jugular nodes. Level 5, posterior triangle. And level 6, nodes of the anterior compartment, the pretracheal, paratracheal, and the precricoid lymph nodes. So this is a slide showing the various level of the neck. The level 1A, level 1B, level 2A, level 2B, the level 3, level 4, level 5A, level 5B, level 6, and this is level 7. What are the anterior triangle borders? The superior border is the inferior border of the mandible, the medial border is the midline of the neck, and the lateral border is the anterior border of the sternocleidomastoid muscle. What are the subdivisions of the neck? The muscular triangle, the carotid triangle, the submandibular triangle, and the submental triangle. So this is the anatomy showing the submental triangle, the submandibular triangle, the carotid triangle, the muscular triangle, the occipital triangle, and the subclavian triangle. Posterior triangle borders. The anterior is the posterior margin of the sternocleidomastoid muscle. The posterior margin is the anterior margin of the trapezius muscle. The inferior border is the middle one-third of the clavicle. What are the subdivisions? Occipital triangle and the supraclavicular triangle. This is the slide showing the occipital triangle, the subclavian triangle, the level 5 dissection, the omohyoid belly, and the superior belly of omohyoid. The triangles of the neck are the topographic areas of the neck bounded by the neck muscles. The sternocleidomastoid muscle divide the neck into the two major neck triangles, the anterior triangle and the posterior triangle of the neck, each of them containing a few subdivisions. What is level 3 lymph nodes of the neck? The level 3 nodes are internal jugular nodes located between the hyoid bone and the cricoid cartilage landmarks. Radical neck dissection. This operation has been used for almost 100 years and describes the removal of lateral neck nodes and tissues to surgically remove cancer in the neck. Included in this tissue, which extend from the collarbone or clavicle inferiorly to the jawbone mandible superiorly, are dozens of lymph nodes. In addition to lymph nodes, this operation often includes removal of the submandibular gland, a saliva-producing gland in the upper neck, the sternocleidomuscle, the jugular vein, and spinal accessory nerve to the trapezius muscle. The radical neck dissection was designed to ensure complete cancer removal in individuals with very advanced cancer in the neck. The radical neck dissection is effective but produces characteristic cosmetic changes. Because so much tissue is removed, one side of the neck may appear flatter than the other. More importantly, sacrifice of the nerve to the trapezius muscle results in visible drooping of the shoulders and difficulty in raising the arm overhead. Some individuals develop pain in the neck and collarbone. An intensive physical therapy program may diminish some of these problems, but some long-term disability can be anticipated. Historically, radical neck dissections were the most commonly performed type of neck dissection performed by surgeons. This is no longer the case. Most patients are candidates for a less radical operation. Comprehensive neck dissection in the previously untreated patient is primarily utilized to treat neck disease greater than NO. Favorable N1 disease may be treated with selective neck dissection. Expanding indications for selective neck dissection may warrant less than a comprehensive neck dissection for favorable N2 disease when post-operative irrigation is planned. In the past, Indication for classical radical neck dissection have been entry neck disease, disease involving the accessory nerve and or internal jugular vein, recurrent tumor after previous irradiation, continuation, recurrent disease in the neck after previous neck dissection, salvage surgery in patients after chemoirradiation, gross extranodal spread or fixation, involvement of the platysma or skin, requiring sacrifice of a portion of skin in the upper neck. In the past, patients with neck cancer persistence or recurrence after irradiation or chemoradiation were generally treated with a comprehensive neck dissection. Radical neck dissection contraindications. NO, extensive disease, carotid artery encasement, deep neck muscular invasion, and skull-base involvement. Modification to the radical neck dissection includes the following. Type 1, the spinal accessory nerve is preserved. Type 2, the spinal accessory nerve and the internal jugular vein are preserved. Type 3, the spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid muscle are preserved. Extended radical neck dissection, resection of lymph node groups, and or additional structure not included in the classic neck dissection is performed. Additional preoperative evaluation, CT scan of the neck. If there is extensive disease around the carotid artery, preoperative evaluation of carotid and cerebral blood flow may be valuable, including 4-vessel cerebral angiography and carotid balloon test occlusion if consideration for carotid resection is entertained. May be a useful preoperative evaluation if the risk of entering the carotid is high, even if resection of the carotid artery is not planned. Consent inclusions: general anesthesia, stroke and or death, neck skin incision with secondary scar, bleeding, infection, swelling, removal of sternocleidomastoid muscle with secondary asymmetry, removal of spinal accessory nerve with secondary shoulder weakness and pain, possible injury to hypoglossal nerve with secondary tongue weakness affecting speech and swallow, possible injury to vagus nerve with secondary weakness in voice and swallow, possible injury to facial nerve with secondary weakness of lower lip and or face, possible injury to sympathetic trunk with secondary Horner's syndrome, possible injury to thoracic duct with secondary Kyle lip, risk of significant facial or cerebral edema, primarily if both jugular veins are removed or injured, possible skin flap loss, possible second surgery. Additional concerns arise when neck dissection is combined with pharyngeal procedures and or when bilateral neck procedures are performed. Risk of salivary fistula, late carotid bleeding. Three common incisions are used. Utility or Leahy incision made in the skin creases of the neck, beginning in the low neck and extending to the mastoid tip. Occasionally, a posterior limb is added. Schubinger incision, which has a high horizontal limb, higher to mastoid tip, and long curving descending limb. This may be most useful in treating oral primary lesions. McPhee incision consists of two parallel horizontal incisions, one high and one low. This is most useful in a post-radiation patient when skin flap necrosis is more common and carries higher risks. Conley suggested a posteriorly curving vertical incision rather than a horizontal incision. Hayes-Martin incision. It's a paired Y incision. Here, the submandibular component is met by a vertical limb which below become continuous with an inverted Y in the suprascapular region. This flap most often gets cyanosed. Flap necrosis and carotid exposure is more common in this type of incision. Schobinger, 1957. Vertical limb instead of being straight should be curved posteriorly. How long does it take to recover from neck dissection surgery? For most people, the swelling starts to go away 4 to 7 days after surgery. You may have numbness in your neck and ear. Your lower lip or shoulder may feel weak. For most people, these problems go away in 6 to 12 months. Counseling and support. Sometimes you and your loved ones just need someone to talk to, someone who's trained to help you make sense of your experience before, during, and after treatment for cancer. Here are some of the problems that can come up during radiation treatment for head and neck cancer and afterward. Serostomia or dry mouth. One of the main side effects is that you will produce less saliva or spit. Radiation caries or tooth decay. Radiation caries or tooth decay is caused by dry mouth after radiation treatment. Osteoradionecrosis or bone death. One of the most severe side effects of radiation therapy is osteoradiation necrosis or bone death. Some of the other problems that can develop after you have had radiation for head and neck cancer include infection, changes in the way food tastes, trouble opening your mouth, swelling and ulcers in your gums, problems with tooth development in younger patients. Head and neck cancer surgery is a journey. Paradigms keep on changing. Please share, subscribe to my YouTube channel, and click the notification button to hear more about the head and neck surgery topics. Thank you.